This video showcases the management of iridodialysis repair, which is huge and massive. This is the undilated image of the eye, and this is the dilated image. So as you see, there is a traumatic cataract which is associated, and there is a huge iridodialysis in this patient. So being a traumatic cataract, the surgeon should initially confirm the absence of vitreous in the anterior chamber, because the management then changes drastically. Luckily, there was no vitreous in the anterior chamber, hence a routine cataract procedure is adopted for this patient. As seen, the capsule is quite fibrotic, but there was no difficulty in doing the capsulorhexis for this patient. So the entire capsulorhexis and the cataract surgery procedure is performed with phacoemulsification and placement of the intraocular lens into the bag. Having done that, in this case, what you see is a three-piece intraocular lens. This is just to be sure that, if there is any procedure, undue development during the procedure, the three-piece intraocular lens can be used to refixate by doing a secondary IOL fixation. Anyway, now the iridodialysis repair is being managed. The iris is being flattened out. Here I'm trying to assess the flexibility of the iris tissue because it is very friable. I try to do a flange technique here. This is a 6-0 Prolene suture which I have taken, and I have made a flange, and I try to engage the peripheral iris tissue into the tip of a 30 gauge. You can also use a 26 gauge needle here. And I'm trying to flange this tissue here, and the Prolene suture is then threaded into it. But this iris tissue is so friable that it does not actually hold the flange. So the moral of the story is that the surgeon should know at least 2 to 3 methods of doing a particular procedure, because if one procedure fails, you can adopt another procedure. And what I'm doing now here is the non-appositional iris repair, wherein I have taken the double arm suture. It enters the eye through the paracentesis incision, which is usually placed diagonally opposite to the area of the iridodialysis. This is the peripheral iris tissue that is engaging, that is being engaged, and then the tip of the needle is threaded into this, and the suture loop is pulled outside. So as you see that this suture loop comes towards the scleral surface, it pulls the iris tissue also along with it, and then the suture is tied. This procedure the surgeon keeps on repeating till you engage the entire amount of the iridodialysis and you fix it to the iris base. Usually with iridodialysis repair, especially with the huge iridodialysis repair, you always need to perform a single pass 4-throw pupilloplasty procedure in order to cover up the correctopia that is being developed. Now this is very important because you do not want that the periphery or the edge of the intraocular lens to cause any glare to the patient. So it is very important to cover the defect out there or the correctopia. So single pass 4-throw pupilloplasty procedure works very well in these kind of things, and this is a combination of 2 procedures. Many times multiple combinations are also needed because iris tissue behaves differently in different tissues. An end opening scissors is used to cut the sutures. It is very important that the surgeon should have this in their toolkit because when you are doing an iris repair tissue, many times you need to go deep into the anterior chamber, and that is where the long flanges of the end opening scissors are helpful. Here you are seeing that single pass 4-throw pupilloplasty is being repeated to correct the big correctopia which is present here. So the entire edge of the optic of the IOL is not seen. Having done this procedure and having corrected this the iris tissue, in these cases it really helps the patient a lot, and this is how the patient looked, and this is the preoperative and the postoperative image of the case.